Needham voters will need to respond to 4 questions on the November 6th ballot. Over the next few weeks, we're going to take a closer look at question 1. This initiative would implement state-mandated nurse-to-patient ratios. The ratio would vary based on each department. A hospital would face a $25,000 fine for each incident of noncompliance. This week, we spoke with John Fogarty, the president and CEO of Beth Israel Deaconess Hospital, Needham, about his thoughts on question 1.
The hospital here at BID Needham, as well as our coalition to protect patient safety, is opposing question 1. And there's basically 4 reasons for it. First of all, I think the most important thing to point out is we're all in favor of safe staffing. We want to make sure our nurses are adequately supported, and we want to make sure that our quality in Massachusetts is top-notch. And frankly, our data shows that Massachusetts already is the #1 quality provider when you compare us to other states. But the reasons that we're opposed for it are, first of all, that the proposal, while perhaps well-intended, takes the decision-making away from the bedside. Every shift, every day, nurses have to decide what is the right amount of care for their patients. That decision is made based on what is the acuity or the illness of the patients, what is the skill level of the staff that they have, not just the nursing staff that are on the floor, but all the staffs. The physician has to participate in that situation. So if question 1 were to pass, none of those things will really be considered anymore. It will all be about the ratio. So it's 4-to-1, regardless of how ill the patients are, whether it's the first shift when things are generally pretty busy, or the third shift when all the patients are asleep, essentially. Our biggest concern is that it takes that decision-making away from the nurse at the bedside and basically makes it a government mandate. Second, in order to comply with the ratios, the hiring requirements for the state's hospitals will be significant. So the estimate is that right now there's somewhere between a 1,000 and 1,500 nurse shortage in the state of Massachusetts. This legislation, if passed, will require another 4,000 nurses be hired just to comply with the ratios. Hospitals that cannot hire to those ratios will have to restrict services in order to meet the ratio. So for instance, I think one of the things that the proposal does not consider is, having worked in this field for almost 30 years, hospital activity and volume is unpredictable. Your emergency room can go from very boring and quiet to incredibly busy in a matter of minutes. So with those kind of changes, your compliance with the ratio will vary radically, potentially on an hour-to-hour basis. It's not realistic that you will have a room full of nurses sitting, waiting idle to be called in if there are 3 or 4 ambulances that pull up unexpectedly to the hospital emergency room. So when that happens, to meet the ratio, nurses will have to be pulled from elsewhere in the organization to staff the emergency room in this instance. When you pull nurses out of an area like an inpatient nursing unit, you have to close beds so that that nursing unit doesn't violate the ratio. When beds are closed, you can't admit patients from the emergency room up to the floors because those beds are no longer open and staffed. What does that mean? That means if you're not in a true emergent situation in the emergency room, then you're waiting. So if you show up with a minor injury or a non-critical medical condition, you're waiting. The proponents of issue 1 would say this will increase access to care, but our feeling is that it will actually impede access to care and increase waits. The third issue is, frankly, we think it's bad for nurses themselves. I have spent a lot of time in our organization talking to our nurses. Now, I'm not going to tell you that every single nurse that I speak to is opposed to question 1. That's fair, that's fine. People are allowed to vote their conscience or have their own beliefs. But the majority of the ones that I speak to do not like having government intervene in the way that they treat their patients. So I'll give you a for instance. A nurse is in the emergency room. They are staffed to the ratio on that particular day. And then there's a code blue, a heart attack, somewhere else in the organization. Well, when a code blue is called, you run to that emergency if you're on the code team. One of our nurses was saying to me that, so you mean to tell me that under this regulation that I'll have to make a choice to run to the emergency room, break the mandated ratio in the emergency room, incur a $25,000 fine for the hospital, or stay in the emergency room and put my license at risk? Most nurses don't want that on their back. So we think that it's a bad thing really for the staff themselves. And the last point, well really two last points, are the cost of the proposal was pegged by the Coalition to Protect Patient Safety at around $1 billion. The proponents of the proposed regulation pegged it at much less than that, $40 or $50 million, which is still not an insignificant amount of money. The Health Policy Commission, which is a nonpartisan state government agency, last week produced their report, which said they believe that the proposal will cost in the area of $900 million every year, forever. It's a complete unfunded mandate. We feel like we've been pretty successful here at BID Needham in growing a stable and successful hospital. But those costs will crush certain hospitals in the state who could be in danger of closing. And unfortunately, those are the hospitals that are in the most underserved areas, where they are treating patients that are most medically needy, that don't have good access to health care, that don't have the financial means to pay for all their health care needs. So those are some of our biggest concerns. The other thing is, some people will say to me, well, John, how could you be against it? It's good for nurses, it's good for quality. Better nurse staffing means better quality. But the Health Policy Commission, in that very same report where they pegged the cost at $900 million, looked to the only other similar program in the state, which is in California, and basically concluded that based on their review, the California program, which has been in operation for about 10 years, has had no impact or improvement in quality in that state. So for those reasons, we feel that it will impede access, it's costly, not good for nurses, and will not have a positive impact on quality.